This chapter discusses the Evaluation and Management section of the CPT Codebook. The E&M section requires a thorough understanding of CPT guidelines and the ability to interpret and understand the documentation provided by physicians and other qualified healthcare professionals. In addition, it requires the coders be aware of any payer-specific guidelines that may affect coding. The various levels of E&M codes describe a wide variety of skill, effort, and time, responsibility, and medical knowledge required for the prevention, diagnosis, and treatment of illness and injury, and the promotion of optimal health. The basic format of E&M service consists of 5 elements. E&M service codes are listed by a unique code number beginning with 99. They generally identify the place or the type of service, for example, an office or outpatient service, or an initial or subsequent hospital care. They define the content, extent, or level of a service, for example, a detailed history or detailed examination. They describe the nature of the presenting problem, for example, how severe the problem is, and identify the time typically required to provide the service. E&M services place of service. As noted prior, it's office or outpatient, hospital observation, which is different from a hospital inpatient. You could code for the E&M service in the emergency department, or in critical care, a nursing facility, a rest home, or even a home visit. Here's an example of a CPT code 99213 for an office or outpatient visit. Here we see that the patient received an expanded problem-focused history, an expanded problem-focused examination, and medical decision-making of low complexity. Generally, a physician may spend 15 minutes face-to-face with the patient and/or the family. So, as noted prior, the examination or explanation of an E&M code, it describes the services given to a patient. So it's the type of service, where the service is provided, what's the extent of that history exam and medical decision making, and then you select the code that matches the service. In 2013, a qualified healthcare professional was described as anyone who has had qualified by education, training, or licensure or regulation, had a facility privilege, and performed services within the scope of practice. It is not a clinical staff. It is an actual qualified healthcare professional. This could be a nurse practitioner or a physician assistant or other qualified health professionals. Here we have a slide talking about a new versus established patient. A new patient is one who has not received any professional services within the past 3 years from the physician or qualified health professional, or another physician or qualified healthcare professional of the exact same specialty and subspecialty who belongs to the same group practice. An established patient is a patient who's received professional services within the past 3 years from the physician, qualified healthcare profession, or other physician qualified healthcare professional of the same exact specialty and subspecialty who belongs to the same group practice. So, if a patient, for example, is an office patient who has not received services, although they have been going to that practice for several years, but they have not been into that practice in 3 years or more, they would be considered a new patient. We need to know this because the code sets for evaluation and management in many areas are based on a new or established patient. The components and elements of an evaluation management. There are always three key components considered: a history of the patient, examination, and medical decision making. These are contributing elements are counseling, coordination of care, nature of presenting problem, and time. So the key components of any visit would be the history, examination, and medical decision making of the physician or qualified healthcare professional. In a new patient level of service, it needs to meet or exceed three of those three key components. An established patient needs to meet two of the three components. So you should read the code descriptions to see which one is applicable. If it's a new patient, you'll choose a new patient, and you will look at those three key components to see if they meet or exceed. Within the history, there's a chief complaint, a history of present illness, a review of systems, a past family and/or social history. These are related to the history and the level of service given, or the level of service given by the physician. In the examination, there are body areas that would be included in the examination of the patient. Head, including the face, neck, chest, abdomen, genitalia, back, and each extremity. There is also the examination of the organ systems: eyes, ears, nose, and mouth and throat, cardiovascular, respiratory, gastrointestinal, genitourinary, musculoskeletal, skin, neurologic, psychiatric, hematologic, lymphatic, and immunologic. So within the history, exam, and medical decision making, the exam would include the organ systems noted by the physician. Then the third key component would be your medical decision making. The physician would decide the diagnosis and then how to manage or treat this patient. He would or she would consider complex data and the amount of complex data. This is listed, that is listed in your book, that you could see what the data could consist of, such as lab reports, tests, and so forth, and old records, new records, things like that. And then the risk factor that the physician would have to take into consideration in treating this patient. The level of medical decision making refers to the complexity of establishing a diagnosis or selecting a management option. So this would include the number of possible diagnosis or management options, as we said, the amount of complex data, and the risk of significant complications. It also concludes the number of diagnosis and management options. So there is a point system that you would use, that would be used, that you could decide the level of medical decision making and the number of diagnosis and management options. Once compiled, we can find out if it's a self-limited or minor diagnosis or management option, or an established problem, whether the patient is stable or improved, or this established problem is worsening, or possibly it's a new problem with no additional workup, or a new problem with additional workup planned. Part of the medical decision making is reviewing lab tests, radiology tests, medicine tests, all this patient data that is required for the physician or qualified health professional to make a decision on how to treat this patient. May include the discussion of diagnostic test results with a performing physician, independent review of an image or a tracing or a specimen, decision to obtain old records or review and summarize old records. So here, part of this medical decision making, of course, is the table of risk, which is in your workbook to review, the presenting problem, why the patient is there, what diagnosis or diagnostic procedures were ordered, and what management options were selected. Within the table of risk, once all compiled, the 4 levels of risk: minimal, low, moderate, or high. Please review the table of risk in your workbook. And then another component, if counseling and coordination of care dominates the visit, is more than 50% of the visit. The doctor would need to document the total amount of time for the visit and then time devoted to counseling and/or coordination. So, for example, the documentation may read that 25 minutes of counseling time was with the patient and 10 minutes of face-to-face discussing a pertinent diagnosis. Time would be the key component here because counseling and coordination of care dominates the visit more than 50%. The E&M key components for a new patient requires 3 key components meet or exceed. So if you have 3 key components and only one meets or exceeds, drop down to the lower level of service to see if those components meet or exceed there. Oftentimes, you'll have 2 of the 3, and therefore you would have to drop down to a lower level, which would meet or exceed the 3 key components to meet or exceed. In the 99212, an established patient, it states that you require for established patients 2 of the 3 key components are met. So once it's met, 2 of them meet the level of key components, you would have your level of service there. In preventive medicine services, 99381 through 99397, there is a distinction between new and established patients. Age is a factor. There will be children, child, and through older person. Services reflect the age and gender appropriate for the history and exam. And comprehensive is not synonymous with comprehensive in the E&M section. Definition is based on specialty guidelines for existence from the American Academy of Family Physicians. So review your guidelines to find out whether a comprehensive service was given.